All right, to continue with developmental dysplasia of the hip, on page 1230, you have the beginning of a purple nursing care box regarding the child with developmental dysplasia of the hip. On your own time, I would like you to read over the purple box. As I've said before, those boxes contain some really great information, and really focus on the part on 1231 listed under interventions. So I want you to focus on the part listed under interventions on page 1231 when studying. That contains great information about what we're going to teach parents about the Pavlik harness and the Spica cast care. Our next disorder we're going to talk about is on 1232, Legg-Calvé-Perthes. It's an avascular event affecting the epiphyse of the femur and prevents further growth of the ossific nucleus, resulting in increased bone density. As the bone is subsequently reabsorbed and replaced by new bone, the femoral head tends to flatten and enlarge. The child usually complains of a painful limp that is exacerbated by activities such as walking or running. And you can look in this x-ray here, and on the right is the normal hip. And you can see that the head of the femur is placed nicely into the socket. And if you look here, the patient with Legg-Calvé-Perthes disease, the head is sort of flattened instead of ball-like and doesn't fit so nicely into that socket. We have those already. So manifestations, what we have listed there: persistent pain of the hip that worsens with movement, deformity with the femoral head flattening and taking a misshapen appearance. Diagnosis can be made through x-ray, bone scan, or MRI. The goal of treatment is to prevent deformity of the hip and delay the onset of arthritis and degenerative joint disease. Anti-inflammatory medications, range of motion exercises, bed rest, traction, Petri cast, abduction braces, and surgery can be used. If you look at page 1232, you have a purple nursing process box for the child with Legg-Calvé-Perthes disease. Please review that purple nursing care box on your own. Next, we're going to move on to clubfoot, which starts at the bottom right of 1233. There's a picture of a child with a left clubfoot. What is clubfoot? It's a congenital dysplasia of all tissue below the knee. Diagnosed, the deformity is easily recognized and diagnosed prenatally by ultrasound. Therapeutic treatment includes the Ponseti casting method and French physiotherapy. If you look on page 1234, the textbook describes the therapeutic management. So the goal of treatment for a child with clubfoot is to reduce or eliminate all of the components of the deformity so the child has functional, structural, mobile, pain-free foot. Additionally, treatment goals include a satisfactory appearance, ability to wear normal shoes, and the avoidance of unnecessary or prolonged treatment. The Ponseti casting method and the French physiotherapy method greatly decrease the need for extensive surgery in these patients. The French physiotherapy method involves daily sequential stretching, strengthening, and mobilization of the foot, followed by taping and splinting to allow for gradual correction of the deformity. Most of the correction is obtained by the physical therapist within the first 3 months of treatment, with full correction expected within 5 months. Committed, well-trained parents are an integral part of the technique, with parents being taught the technique early on and home therapy continuing until walking age. Splinting continues until 2 or 3 years of age in an effort to prevent recurrence of the deformity. Under Ponseti casting method, by far the standard of care for clubfoot treatment is the Ponseti casting method. It's basically a serial casting method. The method requires weekly gentle stretching and manipulation of the misaligned bones, followed by application of well-molded long leg plaster casts. The Ponseti method corrects all the components of the deformity simultaneously. Correction of the deformity is usually obtained within 6 to 8 weeks of casting. Under clubfoot reoccurrence, despite the differences between Ponseti casting and the French physiotherapy method, both have been shown by MRI to be effective in achieving and sustaining normal bone and joint alignment in the foot. Unfortunately, there are still club feet that ultimately require surgical interventions. Under education and anticipatory guidance, prepare the families for expected disruptions in the child's care, such as difficulty with dressing, sleeping, and playing. Often seen with the initiation of casting and bracing. Knowledge that the child will adapt, usually within 24 to 48 hours, is helpful for families. Families must receive thorough and ongoing education about proper neurovascular care, skin and pain assessment to prevent potential problems. Positioning, bathing, and skin care must also be addressed with clear verbal and written instructions. Both the Ponseti casting and French physiotherapy treatment methods obtain the best results when the infant is relaxed during manipulation of the foot. Infant feeding should be timed to coincide with the treatment session to aid an infant distraction and relaxation. A calm, quiet, warm environment with dim lights, soft music, and parental involvement is comforting to the infants and helps them relax and even sleep during the session. If surgery is needed, the nurse oversees pain management. Elevate the child's feet postoperatively to reduce swelling and pain, administer analgesics, and assess the neurovascular status of the toes at least every 2 hours. Next, we're going to talk about osteogenesis imperfecta. There's a small section about this on page 1240 at the bottom of the purple box. Is characterized by connective tissue defects and extreme bone fragility. Its most common manifestation is frequent fractures, even with the slightest injury. The earlier the fracture occurs, the more severe the disease. Shorter stature, spinal and long bone deformities, and osteoporosis. Let me see here. Most common manifestations is frequent fractures, even with the slightest injury. The earlier the fracture occurs, the more severe the disease. Other characteristics of people prone to having osteogenesis imperfecta include the short stature, spinal and long bone deformities, and osteoporosis. Infants with type 2 usually die during the perinatal period or early infancy. Older children need gentle handling and movement, injury prevention, nutritional management, enhanced family and child coping, and chronic condition. With a chronic condition, IV biphosphonate may increase bone density, so that might be a medication used. So think about the description of this disease and think about what layman's term you might have heard used to describe this disease. Okay, were you able to think of anything? So we're looking at osteogenesis imperfecta. Common manifestation is frequent fractures, even with the slightest injury. Were you able to think of another term that might be used for that condition? If you thought of brittle bone disease, you are correct. They are one and the same. We're going to move on now to osteosarcoma. We're going to flip to page 1162 to talk about that. It's the most common primary bone malignancy in children. The cause is unknown. It originates from bone-producing cells that invade the medullary canal of the bone and form a solid tumor. Incidence is higher in the most rapidly growing bones, such as distal femur, proximal tibia, proximal humerus. The highest risk period is adolescent growth spurt. Manifestations can be progressive, insidious, or intermittent pain at the tumor site, a palpable mass, limping, progressive, limited range of motion, and pathological fractures at the tumor site. Diagnostics include biopsy, X-ray, CT, MRI, and labs. The therapeutic management goal is to remove the tumor and prevent the spread of disease. This is accomplished through surgery and chemotherapy. For extreme cases, amputation may also be needed. If you look on page 1163, there is a purple nursing care box for caring with a child with osteosarcoma. Please review that box and pay special attention to what's mentioned under interventions. Finally, we're going to talk about Ewing sarcoma on page 1164. Ewing sarcoma is the second most common bone tumor seen in children. Manifestations include pain, soft tissue swelling around the affected bone, fever, Symptoms are based on the site of the tumor. So for instance, if the tumor's on the vertebrae, neurologic symptoms will be seen. If the tumor's on the rib, respiratory symptoms may be seen. Therapeutic diagnosis is made by biopsy, and therapeutic management includes chemosurgery and radiation.